Examination of the tendons and the tendon sheaths. So the tendon, it connects muscle to bone. It functions as it moves a joint. It's made of fibrous connective tissue. The tenocytes are located between the collagen fibers and the glycoproteins. There are several collagen fibril subunits which are forming the whole tendon. The blood supply. There's no blood vessels within the tendon. The blood supply is from surrounding muscles, bones, and tendon sheath. The stress and strain curve. So irreversible damage beyond the yield point causes a rupture. Regeneration never happens. And the repair or remodeling is scar formation, incomplete replacement, and a type 3 collagen. The tendon sheath. It surrounds the tendon and helps protect it from abrasive damage as they move. And the digital flexor tendon sheath, or the DFTS, is seen here. And then you have the superficial digital flexor tendon, the deep digital flexor tendon, the check ligament, and the suspensory ligament. So the superficial digital flexor tendon, or the SDFT, it starts from the medial epicondyle of the humerus and goes onto the phalanx on the medial side. The manica flexor is a structure from the superficial digital flexor tendon that wraps around the deep digital flexor tendon within the tendon sheath. The common injuries are in racehorses due to traumatic overreach. The deep digital flexor tendon, or the DDFT, it's typical in show jumpers or show eventers, and a complete rupture makes the toe flip upwards. And the prognosis is poor. The suspensory ligament. These are structures which stabilize normal hyperextension of the fetlock. It runs down the palmar or plantar aspect of the cannon bone between the splints. It originates at the carpus or the tarsus, and it inserts on the pastern bone. And then you have the muscle, the interosseous muscle, the palmar annular ligament, and the digital annular ligament, and the accessory ligament. And in incomplete rupture, the fetlock drops, and there's severe hyperextension, as seen here. Also seen here and here. And the peroneus tertius rupture. So the pathogenomic clinical signs are a horse is able to extend the hock while the stifle is flexed. It's able to bear weight on the limb. And at trot, there's overextension of the hock, there's lameness, and there's delayed protraction of the limb, the affected limb. And the digital flexor tendon sheath, or the DFTS. So the distal third of the metacarpal it starts at the distal third of the metacarpal or metatarsal bone to the navicular bone. And the manica flexora originates at the medial and lateral aspects of the superficial digital flexor tendon, and it wraps around the deep digital flexor tendon, as seen here. So superficial, deep, manica flexora. And the disorders are, it can be bilateral when it's a cosmetic problem, unilateral, causes swelling. Non-septic tenosynovitis is common in sport horses, and it just makes big swollen at the back. And the palmar annular ligament. So it can have a syndrome. This is a thickening of the palmar annular ligament, and it's from external trauma, overextension of the fetlock. It causes thickening or chronic inflammation and leads to compression of the deep flexor tendon sheath. And seen here, it's very thick. And diagnostic analgesia. So for the deep digital flexor tendon, use distal 4-point block. For a high palmar block for the superficial digital flexor tendon. Suspensory ligament, use the lateral palmar analgesia. And then for the deep flexor tendon sheath and the annular ligament, use a low point 4-point nerve block. Have a lateral medial approach, 10 to 15 millimeters, and you have an proximal palmar approach and a distal palmar approach. For ultrasound, you can see the fiber pattern of the superficial digital flexor tendon sheath or the deep digital flexor tendon sheath and the thickening of the palmar annular ligament. And for the tendography, so use a radiography of the tendon and use a contrast material. Use 5 to 7 milliliters of meglumine diatriazote, and then have a lateral view. And then you can see the manica flexora and tears in the deep digital flexor tendon sheath, and you can have a standing ultrasound as well to see the superficial digital flexor tendon sheath and the deep digital flexor tendon sheath.